Good day, everyone, and welcome to the Perak Trauma Life Support 2022 edition. My name is Dr. Ravindrapany, and I'll be presenting to you the topic about thermal injuries today. My apologies first for not being able to provide an image of myself due to some technicalities. But not to worry, we will be meeting during the practical sessions anyways. Thermal injuries are underappreciated injuries that are associated with substantial morbidity and mortality. Of great importance is that these injuries affects not only the physical health but also the mental health and quality of life of the patient. Often in emergency department, we are faced with a plethora of challenges during the acute and critical management of these patients, as applying the principles of trauma approach with appropriate and timely treatment and resuscitation has shown to minimize the morbidity and mortality of these injuries. Speaking of principles, three vital ones focus on when dealing with burn injury cases include: firstly, look out for airway compromise, especially in suspected inhalation injury patients. Always have a high index of suspicion. Second is maintaining hemodynamic stability. As multiple forms of dysregulation processes are ongoing, the key is to know what to do and what to anticipate. And thirdly is correcting and restoring fluid and electrolyte balance. The first organ that is associated with burn is skin, which happens to be body's largest organ, and we are covered by it literally. It has a few important roles, like it is a protector for underlying tissues from injury, it acts as a temperature regulator, it also acts as a tight seal by keeping body fluids within, and it is a sensory organ itself. Therefore, injuries to skin results in impairment of those functions, leading to dysregulation of body temperature and water balance, plus infection, of course. As important it is to resuscitate, it is also vital to determine the depth and extent of damage. This is crucial as we need to decide where and how the patient should be treated. This is a part of optimizing treatment with specialized care if needed. Most common serious potential complications related to burn injuries, both short-term and long-term, include: number one is fluid and electrolyte loss and hypovolemia, which is actually due to massive capillary leakage. Next is your hypothermia, infection, and acidosis, which is due to the loss of function of the skin itself. And next is increase of catecholamine and cytokine release, which due to hyperinflammatory response, which leads to vasoconstriction, which will not only impact cardiac function but also gives us a tough time accessing a venous access for the patient. Next would be renal and hepatic failure, which is because of multiple dysregulation processes leading to multi-organ failure, and also formation of eSCAR and other complications from circumferential burn, which includes airway edema, uh, apneic breathing due to chest wall rigidity, and also compartment syndrome. Although all burn injuries involve tissue destruction due to energy transfer, different causes can be associated with different physiological and pathophysiological responses. Therefore, it is important to know the types of burn injuries. As you can see, thermal burns can be divided into skin injury and inhalation injury. Chemical burns, you have skin inhalation and mucous membrane injury. Here, it is important to know the causative agent because we want to know whether it is a colliquative or coagulative necrosis we are dealing with. And apart from that, if um, there is an antidote available, it would be a lifesaver. Okay. And next is electrical burn, for example, lightning, which is entirely different as damage inside might be greater than the visible skin injury. And lastly, radiation burn. So the most common is the first type, which are thermal burns. Okay, these burns are caused by flames. Okay, you can have a deep burn from flames itself, or you can have contact burn from hot objects, or you can have burns from flammable vapor, or you can have these scald injuries from steam or hot liquids. Moving on to classification of burn, the system has moved away from the traditional first, second, and third degree nomenclature to a more physiological classification, which is superficial, partial thickness, which is divided into superficial and deep, and thirdly is full thickness. Superficial thickness involves the epidermis, which is a very thin layer, usually less than 1 millimeter in most areas, and it functions as a layer of protection against bacteria and moisture loss. Here, the skin will appear erythematous and mildly painful with brisk cap refill. Note that edema can occur but no blistering. Classic example would be sunburn, and usually it heals in 7 days. A superficial partial thickness burn goes beyond the epidermis to include the superficial dermis. These burns can have blisters, look wet, tend to be more painful but still have a fast cap refill time, and healing can take up to 2 weeks. Whereas a deep partial thickness burn or deep dermal burn goes beyond the superficial dermis to include the deep dermis. These burns can look cherry red or pale and have sluggish cap refill. They may be less painful as more nerves have been destroyed, healing up to 6 weeks and generally require grafting. The major difference between the first and second degree burn is due to the dermis involvement, which is considered the brains of the skin because it is rich in functional elements such as nerves, sweat glands, hair follicles, and blood vessels. A full thickness burn involves all layers of the skin and subcutaneous tissue with involvement of underlying fascia, muscle, and bone. They often look waxy, pearly gray, or leathery, black charred appearance. They are usually painless and there is no cap refill. Treatment is always surgical. So pitfalls to avoid during burn assessment would be: do not use paint to exclude full thickness burn because burns are often mixed in depth. Next is both deep partial and full thickness burns may not blanch. And third, burns are dynamic wounds. So it is difficult to estimate the true depth of a wound for at least 48 to 72 hours. Calculating the total body surface area based on the burn size estimation is crucial in determining initial fluid resource as well as potential disposition. Many of us are well aware of the rule of nines for both adults and peds, whereby these charts are readily available in our EDs. However, recent studies have shown the rule of nines may be inaccurate and can overestimate total body surface area by about 20%, which can lead to over-resuscitation. The Lund and Broder chart is used nowadays whereby it has been proven to be accurate and to have an excellent inter-rater reliability. It is highly recommended for burns more than 15% total body surface area. As for burns lesser than 15% total body surface area, rule of palm is noted to be highly accurate and easy to use. The palm represents 1% of the body surface area, which is same in both adults and peds. In advanced countries, new approaches include computer-assisted programs to assess the burn size estimation. Apart from assessing the extent of burning plus the body surface which are affected to determine the severity of burn, other important factors to consider include whether it's a adult or pediatric patient, what are the other pre-existing medical condition, what are the other associated trauma such as blast injury or fall injury or airway issues, and not to forget non-accidental injuries or abuse, which can actually involve both pediatric and geriatric population. Assessment of a burn patient is done as per ATLS protocol by conducting primary and secondary survey. A close attention is needed on the history part. Nature of injury is vital to exclude any concurrent toxicology involvement, and we also would like to assess for any other associated injuries. Most commonly can be fractures, traumatic brain injury, thoracic or abdominal injuries. And we will also need to know the time of the burn injury, as it is vital to initiate fluid resuscitation. And of course, what are the past medical illnesses and allergies? Patient age matters as well, as age less than 2 or greater than 55 have an increased incidence of complications. Burn configuration is also a big consideration, as circumferential burns can cause total occlusion of circulation to an area due to edema. It also can restrict ventilation if it's around the chest wall, and burns on joint area can cause disability due to scar formation. Other critical burn criteria include third degree burns more than 10% body surface area, or second degree burns more than 30% body surface area in adults and 20% in pediatrics. Burns which involve respiratory injuries such as in inhalation injury cases. Burns over hands, face, feet or genitalia. Burns which are complicated by other trauma, and if the patient has other underlying health problems, and of course if it's an electrical or deep chemical burn itself. Apart from that, moderate burn criteria involves third-degree burns, which are 2 to 10% body surface area, second-degree burns, which are 15 to 30% body surface area in adults and 10 to 20% in pediatrics, burns excluding hands, face, feet, or genitalia, and without any complicating factors. Minor burn criteria are third-degree burns lesser than 2% body surface area, second degree, which is 15% in adults and 10% in pediatrics, and first degree, which involves lesser than 20% body surface area. So what to do when we encounter a burning patient in person? So first and foremost is we try to remove from danger, which is by moving to a safer place if possible. But this is done only by keeping yourself safe first. Okay, next is to stop the burning process itself, is by either extinguishing the fire or remove the clothing or jewelries. Cut around those clothing which are stuck to the skin, and cool adherent substance, which are usually the tar or plastics. Okay, this is best done just by pouring water. Okay, do take note that do not apply any ice, as it causes severe vasoconstriction and can deepen the burn. And in certain local cultures, there might be application of fluoride, which is comes from toothpaste or some other herbal materials, which might complicate into a chemical burn. Approach to the burn patient just like any other trauma patient, but have a high index of suspicion for toxicology involvement as well. Perform your primary and secondary survey as you normally would and address the burns later. As mentioned in the beginning, it is crucial to assess the airway and breathing thoroughly, as airway can become obstructed not only from direct inhalation injury but also from massive edema resulting from burn injury. Therefore, look out for soothing or singeing involving mouth, nose, hair, face or facial hair, whether there's any blackish sputum with persistent coughing, or any history of enclosed fire environment. Do not forget the C-spine immobilization, and bear in mind airway compromise kills in seconds. Next is administrating 100% oxygen via a non-breather mask, and it is given usually in moderate and or critical burns, patients who are unconscious, and whereby there are possible signs of airway burn and inhalation injury, or there's history of exposure to carbon monoxide or smoke. Compromise in breathing usually kills in minutes, and the three main causes for breathing compromise include hypoxia, your carbon monoxide or cyanide poisoning, and your inhalation injury with multiple combustion agents. Parameters such as respiratory rate and SpO2 readings are not reliable due to the risk of tox effects. Look hard for inhalational injuries, as you might consider early intubation. A more detailed elaboration will be discussed later on inhalational injury and intubation. Next is assessing your circulatory status and initiating fluids. Goal is to maintain perfusion and avoid overfluid resuscitation. Burns are associated with significant fluid shifts and losses due to local and systemic changes in vascular permeability. In the first 48 hours, patient actually can develop burn shock, which is a combination of hypervolemic, distributive, and cardiogenic due to massive dysregulated inflammatory response. However, burns do not cause rapid onset of hypovolemic shock. If present, look in and out for other injuries. Assessment can be really challenging, particularly in circumferential burns, as it reduces perfusion to extremity. Primary aim would still be to look for life or limb-threatening causes. And then, as a part of secondary survey, burn surface area is assessed as well as thorough head-to-toe examination is done to look for other associated injuries. Pain management should be a priority. It is the fifth vital sign, and therefore pain treatment should be early and aggressive. Have a low threshold to include narcotic agents given the severity of pain associated with burns. Wound care includes cleaning or cooling using sterile water, thus helps keep the environment moist, which promotes reepithelialization and prevents cellular dehydration. Just be wary of the risk of hypothermia. Use non-adherent type of dressing if needed. Avoid silver sulfadiazine. This is because it delays wound healing and also can further foster microbial colonization. Avoid iodine as well as it is cytotoxic. Next is optimizing the fluid therapy, which we shall talk in detail a bit. Due to the various factors contributing to the magnitude of response, which in combination creates complexity and it requires an individual approach. Ideally, fluid resuscitation therapy is initiated for deep, partial, and full thickness burns, more than 20% total body surface area in adults and more than 15% in peds. Other criteria include more than 10% of third degree burn, more than 15% of second degree burn, more than 30 to 50% of primary and second degree burns. The choice of fluid is a balanced crystalloid, most commonly Ringer's lactate. Children, however, require additional maintenance. The traditional Parkland formula is a passe as it tends to over-resuscitate, leading to complications such as abdominal compartment syndrome, orbital compartment syndrome, and the need of escharatomies, impaired gas exchange, and prolonged ventilations. Experts recommend a lower starting point, thus, the modified Brooke-Parkland formula is preferred. This is about 2 to 4 meals times the percentage body surface area involved times the weight. And the total meals are divided into first half, which is given in the first 8 hours, and the next half is given over 16 hours. Burns from flames and skull. Fluid therapy is started at 2 mils per kilo for adults and at 3 mils per kilo for kids. Aim for an hourly urine output of 30 to 50 cc per hour in adults and 1 cc per kilo per hour in children. For electrical injuries and inhalational injuries, a higher rate at 4 mils per kg is initiated for all ages, with higher urine output target at 1 to 1.5 mils per kilo per hour. Children less than 30 kilos require maintenance, which is half normal saline dextrose 5%, and children less than 1 year of age usually need addition of dextrose. You can increase or decrease resuscitation fluid rate by 30% if hourly urine output target is not achieved. Key concepts and strategies pertaining fluid resuscitation are: first, over-resuscitation is just as harmful as under-resuscitation. Second, formulas are just a starting point. You always need to titrate to urine output from time to time. Next is avoid boluses whenever possible as they increase risk of compartment syndrome. Next, avoid vasopressors whenever possible as vasoconstriction may devitalize burnt tissue. Next is securing intravenous access can be a serious challenge. If peripheral IV line cannot be obtained, consider central venous access or IO. Next is treatment is adjusted to individualized response. In in cases with rhabdomyolysis and acute renal failure, the normal urine output expectance cannot be used as a higher unit output is targeted. Next is note that more is not better. Constantly monitor for fluid overload, which is also known as fluid creep. Overly aggressive fluid administration leads to pulmonary edema, compartment syndromes, and excessive local edema. Managing the pain is of paramount importance as it not only affects the hemodynamic parameters but also the outcome of healing, psychological trauma, and thus quality of life. In ED, opioids like morphine and fentanyl are commonly used and proven to be effective in controlling extreme pain. For example, morphine has a good pain control and it has some vasodilation effects as well. Ketamine is also useful due to its analgesic and dissociative properties. In advanced countries, intranasal fentanyl and ketamine are being used especially in pediatric cases. Treating the burn wound would be your lowest priority. Settle the ABCs and initiation of fluids first. Key is to keep the wound area clean and protected from contamination. So clean it with sterile water and cover it with sterile dressings or burn sheet. A moist environment is more favorable. However, hypothermia is a major concern. Managing blisters is somewhat controversial. Ideally, it is not advisable to rupture the blisters, as the blisters itself can act as a mechanical barrier to prevent exposure to microorganisms while keeping the internal aspect of the wound moist. However, some burn experts practice de-roofing or debridement of the blisters as they believe the blister fluid within can deepen the burn, house an infection, and importantly, they prohibit proper assessment of the wound. Mortality of inhalational injuries is about 10 to 30% and increases with greater total body surface area burns. Be particularly suspicious of a significant inhalational injury if the patient or the first responder reports he or she was in an enclosed space for a minute or more. The following signs and symptoms can be observed to anticipate respiratory problems. When you have burns around the head, face, neck, or chest region, nasal or eyebrow hairs are singed, your presence of hoarseness of voice, patient is tachypneic, loss of consciousness in the burn area, your nasal or oral mucosa is red or dry, soothing in mouth or nose, you're coughing up blackish sputum, and of course, as mentioned, the history in an enclosed burning area. Inhalation injury can be divided into three types. Upper airway thermal injury, characterized by supraglottic injury, mostly manifests with stridor, hoarseness, facial burns, oropharyngeal soothe, and on visualization, you actually can see the pharynx often edematous and there will be mucosal slough. Second subtype is lower airway chemical injury, which involves distal airway and bronchi. These injuries tend to be due to chemical pneumonitis from products of combustion, which are superheated steam, scalding liquids, or toxic chemicals. Usually symptoms are delayed rather than immediate, such as wheezing or crackles, having productive cough, or bronchospasm. Subtype is systemic toxicity due to products of combustion, most commonly carbon monoxide and cyanide poisoning. Apart from history of entrapped in closed environment, an immediate arterial blood gas will be essential in determining the serum carboxyhemoglobin level. Administration of 100% oxygen alone reduces carboxyhemoglobin half-life from 4 hours to 45 minutes. As compared to carbon monoxide, cyanide poisoning can present in similar history, signs, and symptoms. However, if there is an unexplained hypotension or unexplained high anion gap metabolic acidosis with a lactate of more than 8, you can consider cyanide poisoning and hydroxycobalamin can be given. While it's critical to anticipate impending airway compromise and securing the airway sooner rather than later, avoiding unnecessary intubation in ED is vital as well. Signs such as singed nasal hairs and facial burns alone are not indicators for intubation. In fact, mild inhalational injuries in patients with normal oxygen saturations and no signs of respiratory distress can be safely observed. Indications for early intubations include when there are signs of airway obstruction or signs of respiratory compromise, when the burn is more than 50% of total body surface area, when there's extensive and deep facial burns, burns inside the mouth, when there is significant edema or risk for edema, and when there is reduced level of consciousness whereby airway protective reflexes are impaired, and when you anticipate transfer of a large burn patient with airway issues. Although the conventional approach to intubation is by using RSI, many airway experts started practicing delayed sequence intubation or awake intubation. This is, however, only done by experts in mostly advanced trauma centers. Few important keynotes to highlight. First, approach using difficult airway elbow, as burn injuries can cause difficulty in both intubating and oxygenating. Second, when intubating, choose an ETT size 7.5 or larger, cause smaller sizes may prohibit passage for bronchoscope later. However, using a very large tube can worsen airway edema. Thirdly, frequently check the tube position after intubation because edema can result in tube displacement. Apart from that, bronchodilators can be used if presence of bronchospasm, but totally avoid the use of diuretics. Other considerations, as mentioned before, is to assess for other burns and injuries. You treat the burn, soft tissue injury, and of course treat the poisoning if suspected. If cyanide poisoning with your cyano kit, and then you can use your positive pressure ventilation and hyperbaric chambers if suspected of carbon monoxide poisoning if indicated. Next is transferring the patient to a center with burn care and with hyperbaric chamber if needed. Criteria for burn center transfer include full thickness burn, partial thickness burn more than 10%, burns to face, hands, genitalia, perineum, or major joints. Other criteria include electrical or chemical burns, your inhalation injury, and when there is a special social, emotional, or rehab needs. Transfer procedures must be coordinated with the burn unit, and all documentations should be done appropriately and should be passed over. So that's all from me today. A few take-home points before I end my session. So for all burn and inhalational injuries, firstly, think of trauma and tox first. Don't get distracted by the burns. Next, follow your ABCs. Remember, these patients can present with rapidly evolving critical airways. Next, treat carbon monoxide or cyanide poisoning if history, exam, or blood gases are suggestive. Next is begin resuscitation with ringer lactate based on specific burn formula. Remember, fluid formulas are starting points only. Titrate to urine output and end organ perfusion to avoid over and under resuscitation. Next is don't forget about risk of other associated injuries. And lastly, pain management is paramount. So start early, aggressively, and reassess often. Thank you.